For the ICL kit, the reusable base unit can be used with either of the two eye fronts. There's an open sky version and a full cornea version. The open sky version has pre-placed incisions. There's a main incision, and then there are two side port incisions, one proximal and one distal on either side. We recommend starting with the open sky version because it can be reused many times for the surgeons to get comfortable with placing the foot plates into the sulcus. Once they're comfortable with that, move to the full cornea version where the surgeon will make their own incisions, plan out the surgery, and have a more complete training experience. To prep the open sky version of the ICL model, we begin with the open sky shell, which has the pre-placed main incision and two paracentesis on either side. Turning over the eye front, we see that the iris has a plastic support ring and then the more flexible iris material. So we're going to place a small amount, 360 degrees, just covering the iris material, not on the support ring. Then we use our reusable base unit, turn over the eye front. At this point, I like to orient the main incision, which I can see here, towards the place where I want it, which is in good alignment now. Then we press the eye front down onto the reusable base unit. We're going to fill in that area with a little bit of water, just to help bring out the red reflex. And then we will take the curved forceps and use them to position the ICL inside the eye, in alignment with the main incision. Fill the eye with additional water. You'll see the red reflex come out. If you add extra water, you'll start to lose the details of the pupil. So we can just wipe that off or tap the eye. So too much, and then we can start to see the details again. If there are reflections coming off the surface, tilting the microscope a couple degrees can help. Now the surgeon can begin working to tuck the foot plates. Now the surgeon can begin working to tuck the foot plates, going through distal paracentesis, for example, and delivering the foot plates with a proper technique, sliding the ICL and getting it into position, and then paying attention to the proximal foot plates to place the ICL. If at any point you need to, you can add additional water to enhance the view. And continue working until all foot plates have been properly positioned in the sulcus. At this point, you should be able to see the marks for toric alignment, and you can begin rotating the lens into proper position. Once the lens is properly positioned, and I should add that this is a 12.6 millimeter lens, we can slide underneath the lens and elevate it on top of the iris, and then begin working again. We will now review the prep of the full cornea model for the STAR ICL kit. Remember, this model does not have pre-placed incisions. We'll begin the prep in the same way as the open sky, using our cohesive viscoelastic substitute. We'll place a ring of the gel just on the iris on the back. Remember, there's a plastic support and then there's the exposed iris. We're putting the gel just on the iris. The next step is then to fill the eye front with water. We will then take the reusable base unit and invert it into the eye to capture water in the anterior chamber. The trick here is to do it so that we don't have an air bubble. As you can see, we did get an air bubble that time. So I will simply open it up, add more water to remove the air bubble, and try again. Inverting the base and attaching it. If necessary, this can be done underwater for a more effective result. Once the eye front is attached and we're happy that there are minimal bubbles in the anterior chamber, the next step would be to plan the surgery and place our marks. We can dry the surface and place any surgical marks, such as where we'll place the main incision and any side port incisions. That can be done with a Sharpie pen. After the surgery's been planned, then we're going to use our gels again. We're going to use both the cohesive and the dispersive viscoelastic in tandem. We will take the cohesive and create a ring all the way around the limbus. This helps to cover the incision points to prevent air bubbles from coming in. It also helps to hold the dispersive gel in there. The dispersive provides a very nice view into the eye and also helps cover the gel and provide better coverage for the incisions. This is to minimize air bubbles inside the eye. We would then make our incisions, paracentesis, main incision, and then we can use the dispersive gel in the small syringe with a small cannula to introduce ribbons of dispersive viscoelastic, such as OcuCoat, into the ocular anterior chamber. At that point, the eye is ready for the injection of the ICL, allowing it to unfold, and then the surgeon can use the manipulator to tuck the foot plate. If at any point the sulcus needs to be refreshed, a small syringe of cohesive viscoelastic with a small cannula can be used for intraocular movements and to add additional viscoelastic agent behind the iris. So when we're prepping, we use the larger syringes for the outside of the eye, cohesive behind the iris, cohesive around the limbus 360 degrees, dispersive all across the cornea and the incisions. And we use the smaller syringes with the smaller cannulas for intraocular work. The dispersive would be to put some in the AC, just like we would use OcuCoat in preparing the eye for surgery for implantation. And the cohesive can be used if we need to refresh the ocular sulcus and perform the maneuvers. I hope that helps.